I'm Evangelos Terpos from the University of Athens School of Medicine in Greece, and I'm here in Milan for the European Hematology Association annual meeting. I'm presenting here two posters presentation about, first of all, the role of Belantamab Mafodotin, which is an antibody-drug conjugate that is used against BCMA for the treatment of relapsed refractory multiple myeloma in combination with bortezomib or pomalidomide and dexamethasone. But I have a phase 1-2 study here in combination with lenalidomide and dexamethasone in intermediate fit and frail patients with newly diagnosed multiple myeloma who are not eligible for transplant. What we have shown in this study that among the 66 patients who have been enrolled in this 1-2 phase study, we have only 3 patients who progressed in a median follow-up of around 2.5 to 3 years, depending on the phase of the study. Very importantly, we found that the best dose that has to be given in first-line therapy is 1.9 milligram per kilogram every 8 weeks for the Belantamab Mafodotin, and the majority of the patients go to every 12-week schedule because of some ocular problems. So, the vast majority of the patients received into this study Belantamab once every 3 months. And despite that, all patients responded to treatment and more than 50% had achieved a complete response. So, based on this study, a phase 3 study comparing Belantamab, lenalidomide and dexamethasone versus daratumumab, lenalidomide and dexamethasone, the DREAM10 is going to start. One of the problems of Belantamab Mafodotin, and I would say probably the most common, is the ocular problem that it creates in the cornea. Belantamab Mafodotin affects the first layer of the corneal. Corneal has 5 layers, the epithelium, and it creates some small cysts there that may create some problems with either gritty eye, sore eye, painful eye, or sometimes problems in the visual acuity, and this reduction may create problems in reading, watching TV, or even driving. Is it common? I would say that from the studies in the relapsed refractory setting, because these are the 2 approvals of the drug, at least in Europe, Belantamab with bortezomib and dexamethasone, or Belantamab with pomalidomide and dexamethasone, almost 60 to 65% of the patients will have no visual acuity problem. The other 1/3 of the patients that may have some ocular problems, this may last for a very short period of time. It is totally irreversible, and in more than 90% of the patient is totally irreversible. And I can tell you that the vast majority of patients, and when I say vast majority, I talk about 95% of the patients, will not have any problems in stopping reading or driving. There may be a subset of patients, very small, around 2 to 3%, that they may stop for a specific period of time to drive or to read, but as I previously mentioned, this is totally reversible within 2 to 4 weeks. So the majority of the patients in the relapsed refractory setting receive the drug every 8 to 12 weeks without having any problems with the efficacy, as the 2 studies, DREAM7 and DREAM8, have shown. Along with other colleagues from all over the world, and also with ophthalmologists, we created some guidance for the everyday practice hematologist how to deal with the ocular toxicity of Belantamab. This is a poster presentation here, and the paper is going to be submitted to American Journal of Hematology for a publication. What we suggest is that during the first 4 doses of Belantamab, it is good to have an ophthalmology examination. At baseline, definitely, to my opinion, because almost all patients above the age of 70 may have some ocular problems like cataract, glaucoma, or something like that. And then, before each one of the next 3 doses, but to my opinion, if there is a problem, in my clinical practice, and as I previously mentioned to you, 60 to 65% will have no problem, then if the patient says, "Doctor, I have no problem," to me, I would not send him to the ophthalmologist again. However, in the SPC of the drug, this is going to be seen for 4 doses to have an ophthalmology evaluation before. How about after the 4 doses? Then what we suggest to the hematologist is to use the so-called vision-related anamnestic tool. This is a questionnaire of 9 questions. The first 5 of them deal with symptoms: sore eye, dry eye, painful eye, or blurred vision or impaired vision. The other 4 questions have to do with daily activities: problems in driving, in reading, watching TV, or watching my mobile or the smartphone. If the patient answers yes to each one of these questions during the last 24 hours, and especially if the patient has that symptom for more than 8 hours within a day, then the hematologist have to delay the treatment of the patient, the dose, till the patient has no symptoms. And if these symptoms continue for more than 8 weeks, then up to 12 weeks, then the doctor, the hematologist, have to refer the patient to the ophthalmologist. But I believe that with the delays and probably with lowering of the dose, very few patients will need to go to the ophthalmology again. So these were the most important part of my presentations here in EHA, and I hope that I will be again with your TV channel in a next conference. Thank you.